Welcome, everyone. We are thrilled to have you join us today for our webinar on the rise tide trends and challenges of lung cancer in Asia. My name is Vincenzo Giacco, and I'm a senior editor at eClinicalMedicine. I will chair today's session together with Shalini Garg, editor-in-chief at Lancet Regional Health Southeast Asia, and Jifang Wang, senior editor at Lancet Regional Health Western Pacific. Before we dive into the content of the webinar, I'd like to share some quick housekeeping with our viewers. You can use the Ask a Question box at any time throughout the webinar, and we will try to answer as many of your questions as we can during the Q&A session. You will also see a box with related resources. This includes a link to the full series on the trends and challenge of lung cancer in Asia. An on-demand version of the webinar will be available and emailed to you once the webinar has concluded. We also kindly ask you if you could complete our short survey at the end of this webinar to help us improve our webinar offering. The Lancet webinar will introduce a cross-journal review series featuring collaboration between eClinicalMedicine, the Lancet Regional Health Western Pacific, and the Lancet Regional Health Southeast Asia, which has launched yesterday, July 8th. The series explores the diverse challenges of lung cancer in Asia and consists of 3 review articles, a commentary, and 2 correspondence on patient perspectives and patient advocacy. I would strongly encourage you to check all these inspiring articles and stories on the series tab. Our agenda for today has an exciting lineup of 3 presentations from our expert speakers, each covering significant aspects of lung cancer in Asia. After the 3 presentations, we will move into a Q&A session. This is your opportunity to ask any question you might have about today's topic. So please use Q&A feature to submit your question. Ultimately, we will wrap up the webinar with concluded remarks. Let me introduce to our speakers for today. Our first speaker is Dr. Rosel de Guzman, medical oncologist at Manila Central University FDT Medical Foundation Hospital in the Philippines. She has particular interest in breast, head and neck, and thoracic malignancies, with a special focus on global oncology, access to quality care, healthcare delivery in resources-limited settings, and the intersection of cancer and climate change. She has served in various roles in international oncology organizations, including the American Society of Clinical Oncology, the International Association for the Study of Lung Cancer, and Oncology Advocates United for Climate and Health International. She has been actively involved in other international programs focusing on improving the multidisciplinary care and access of patients to quality cancer care, especially in low and middle income countries. She has participated in organizing and conducting multidisciplinary cancer management courses in Asia in partnership with cancer societies, organizations, and patients advocacy groups. Our second speaker is Dr. Kumar Prabhash, professor at medical and medical oncologist at Tata Memorial Hospital, and has more than 2 decades of experience. He is the president of the Indian Cooperative Oncology Network. He has published over 100 research and review articles in journals of national and international repute. He is a member of many international and national scientific societies and associations, and has delivered talks at several conferences. These days, he is proactive in increasing awareness about lung cancer and has successfully conceptualized Lung Cancer Consortium Asia and contributed to translational and clinical research work in the field of lung cancer. Our third speaker is Dr. Ilong Wu, a tenured professor at the Guangdong Provincial People's Hospital, the Guangdong Academy of Medical Sciences, and the Guangdong Lung Cancer Institute at the Southern Medical University in Guangzhou, China. He has been the principal and co-principal investigator on more than 90 national and international multidisciplinary clinical trials and has participated in key clinical trials that have changed treatments for lung cancer. Dr. Wu has led and served in many other organizations, including the Chinese Lung Cancer Society as director, the International Chinese Society of Thoracic Surgery as president, and the International Association for Study of Lung Cancer, the European Society for Medical Oncology in China, and the American Society of Clinical Oncology. Dr. Xiyang Mengli Liu is an assistant professor at the first affiliated hospital of Jinan University and a member of the Chinese Thoracic Oncology Group and physician of Clinical Trial Project. She studied under Professor Ilong Wu and Professor Yang Qiu Li at the Institute of Hematology of Jinan University. During her PhD and postdoc research, Dr. Liu mainly engaged in clinical trials related to lung cancer and research on biomarkers conversion. Dr. Liu will join us for the Q&A session and will be keen to take any questions. Please join me in welcoming our first speaker, Rosel de Guzman. Over to you, Rosel.
And I am delighted and honored to be here and to share what we are presenting in the journal. So first and foremost, why lung cancer and climate change? Asia as a region has almost half of the global burden in cancer, and lung cancer is the second most common and the top cause of mortality from cancer. And we are seeing the impacts of climate change, how this intersect and the elements that are interconnected. We will learn more about this as we go through this presentation. So greenhouse gas emissions, mainly carbon dioxide, methane, and nitrous oxide, are being emitted and being responsible for global warming. And we are seeing this based on what we are seeing in the environments, what's happening in different countries. So what happens is the greenhouse gases traps the heat that's supposed to escape to the space. So global warming is an important driver of climate change. And as a result, we are seeing melting of ice caps and glaciers, rising sea levels. There are shifts in weather pattern. We are seeing increased intensity in heat waves, as well as the exacerbation or worsening of air pollution, particularly the component PM2.5, which is known to be carcinogenic. And in most countries in Asia, we are seeing what extreme weather events as a consequence of the escalating threat of climate change. Now, this disaster impacts Asia in huge number in terms of fatalities, the number of people affected, and in addition to economic losses. So most of the disasters that happen in Asia include flooding, cyclones, droughts, heat waves, and is based on the record in 2022. Out of the total 10 countries most affected by natural disasters, 7 of which are in Asia: Indonesia, China, India, the Philippines, and Thailand. And these are the same countries with the most number of cases of lung cancer. Cumulatively, In total, these comprise almost 1 million of the number of lung cancer cases. Now, in 2020, there are more than 1 million of new cases of lung cancer in the region. There's more than 1 million of deaths due to lung cancer. And it is projected by 2040, there will be over 2 million new cases, as well as 1.9 million estimated deaths due to lung cancer. So these figures reflect the burden and the challenge that the region is facing due to the double impacts of lung cancer and the impacts of climate change. So what are the key factors that influence climate change impact on lung cancer care? We see worsening air quality, including, as mentioned, PM2.5, which is a known carcinogen, as well as other environmental air pollutants that are known to be carcinogenic as well. And these impact health. We know that air pollution, prolonged exposure to unhealthy air may cause lung cancer even in individuals who have never smoked. And those patients who are diagnosed already with lung cancer, when they're exposed to air pollution, they have increased mortality. And in South Asia, most of these polluted cities are located in South Asia. 37 of the 40 most polluted cities are located in the region. Most of the air pollution increased in most of the countries, namely India, Nepal, Bangladesh, and Pakistan. And there are millions of people being exposed to this unhealthy air. Other factors that impact climate change on lung cancer care are extreme weather events. There are 81 climate and water-related disasters, as well as more than 83% comprising flood and storm events. More than 50 million people were directly affected, and there were deadliest flooding with thousands of fatalities in Afghanistan, Bangladesh, India, Nepal, and Pakistan. We also witnessed in 2022 the prolonged and dry heat wave that happened in the northern part of India and Pakistan. And we know there are vulnerable population exposed to this dry and prolonged heat wave, particularly the elderly population. In 2020, there were almost 1 million lung cancer diagnoses in the region, which are aged 60 years old and above. And we expect by 2050, there will be more than 1.3 billion who will be age 60 and or older. In Asia, Hong Kong, South Korea, Japan share the highest number of elderly population. So this will be a great challenge for healthcare system in Asia. Another factor is healthcare system resiliency, where most of the infrastructures, particularly healthcare facilities, may be vulnerable to the impact of climate change. There are hospitals, treatment centers, and clinics that may be located in low-lying areas or coastal areas that may be very vulnerable to the effects of typhoons, flooding, and strong cyclones. The capacity and adaptation may be varied based on the resource settings of different facilities. Other factors include socioeconomic, where most of the people who are affected by extreme weather events may be displaced. They may even migrate to other areas in order to avoid the impacts of extreme weather events. And most vulnerable are the patients who are residing in low and middle income countries. Public health policies may be diverse and varied based on the different countries, systems, and political situations in different countries. So what is important is the focus on public awareness and education, regulation of air quality, as well as the promotion for use of clean energy. Climate change also impacts ecosystem and biodiversity, and this may affect the security in terms of water and food provision for patients, communities, and other groups. Now, the exacerbating effects of climate may impact different aspects of lung cancer care. Screening, early detection, diagnosis, including precision medicine, different forms of treatment, whether that's surgery, medical treatments, radiation therapy, as well as research and clinical trials. We know that air pollution with those elements including PM2.5 and other carcinogenic substances, despite being known to be carcinogenic, are not included in risk predictive models. The use of low-dose CT scan, which is proven to decrease the mortality of patients who will be diagnosed of early lung cancer, will have improved outcomes, but the use of low-dose CT scan is not always a priority, especially in resource-limited settings where national screening programs are not well integrated, implemented in their national healthcare programs. Displacements may affect also access to screening programs and services. Pakistan, Philippines, China, and India have the highest number of internal displacements due to disaster. So people tend to move, relocate, and go to safer areas in order to avoid the impacts of climate change, impacts to their health, impacts to their livelihoods, and in order to survive and able to continue on with their lives. Economic stress also leads to prioritize immediate needs. There may be patients who would be preferential to prioritize basic needs such as water, shelter, food, instead of going for a screening test. Precision medicine is, we have witnessed how important it is in terms of diagnosis and treatment, especially in Asia, where there's a high prevalence of EGFR mutation and ALK rearrangement. So access to biomarker testing facilities could impact because there may be situations where the networks, transportation, even transport of tissues and blood samples or specimens are already not really in place in most of countries in Asia. There are situations where tissues and blood samples may need to be transported to a different region or to a different country or different area, and this may be impacted by extreme weather events and damage to physical structures and infrastructures. So delays in treatment, including surgery, systemic therapy, and radiotherapy, may be impacted by the effects of climate change. In a study, there's a 6 to 8% increased risk of death for every 4-week delay in surgery. And in another study, there was disease progression within 24 days when patients were monitored by doing a serial FDG PET and those who were planned for chemoradiation. So the impact is that the importance of MDT, multidisciplinary care, may be further fragmented when there's damage to infrastructures wherein healthcare professionals themselves become affected by the impacts of climate change. There may also be physical, psychological, and mental health impacts. Destroyed medical records, biopsy specimens may go submerged underwater. There may be disruptions in supply chain and transportation networks, and challenges also in drug pharmacokinetics because the fluctuations and changes in the weather may impact these drugs, because most of the drugs being used in oncology have complex storage and administration process. Clinical trials are an important aspect of the way we manage patients in the field of oncology. More than 40% of global clinical trials on non-small cell lung cancer is in Asia. So study sites, operations may be affected because of damage to infrastructures, blocked roads, attendance of study subjects and site staff, damages to research facility, as what we learned from the lesson from COVID-19 pandemic. There were decrease in the number of total patients enrolled in lung cancer trials, and majority of the barriers are due to willingness and the ability of the patients to visit the site. So what is important is to understand how can we adapt and mitigate these impacts of climate change. And which is important is you have to foster collaboration and communication, leverage technology and telemedicine, be resilient in terms of infrastructure, monitoring systems. We have to advance research and provide timely treatment planning, and educate and empower. So there should be an important collaboration between healthcare institutions, cancer centers, different agencies, community organizations, and share best practices, enhance communication channels in order to disseminate information. We have to expand telemedicine services. We have to continue on using telemedicine. It does not only allow patients to continue with their treatment and to monitoring them remotely, but it will also help in terms of lessening fossil fuel emission from transportation. Infrastructure resilience, as we all know, it's important not only to be reactive, but be more proactive and facilitate medical facilities to be equipped to withstand extreme weather events, power outages, and other disruptions. So monitoring also and provide early warning systems so that patients may be able to have adjustments in their treatment plans and schedules, monitor and analyze health data to inform what will be the care strategies and resource allocation, and providing adequate funding and support in order to inform evidence-based strategies, because there's not much research support to understand the impact of climate change to patients with cancer. We have to enhance preparedness and patient safety, ensuring that, and perhaps also what is important is adapting the clinical guidelines we're using in oncology to consider the risks related to climate health. And also educating not only ourselves, the oncology professionals, our colleagues and communities, but educating and empowering our patients and understanding their health risks. So to conclude, the intersection of climate change and lung cancer in Asia is a critical health issue. Climate change exacerbates lung cancer burden, and the projected rise in the cases and deaths need urgent proactive measures. We have to understand that long-term risk of environmental carcinogens are increasing beyond air pollution. And the stressors related to climate may impact not only the physical health of patients, but also their psychosocial and mental health. Climate also impacts existing health disparities, especially among vulnerable populations, including the elderly patients. And oncology professionals and stakeholders must enhance the education, the awareness, and advocacy efforts in addition to research. So all these strategies to adapt and mitigate the impact of climate change require proactive and concerted action. Thank you very much for your attention.
Thank you very much, Roselle, for your fantastic presentation and for telling us more about the significant impact of climate change on lung cancer in the area. We are now moving to our second speaker, Dr. Prabhash. Dr. Prabhash, can you speak? Can you hear us? I'm sorry, because we are having a bit of issues with Dr. Prabhash, so I'll pass to Shalini to just give us a brief introduction about the uniqueness of lung cancer in Asia review. Over to you, Shalini.
Thanks, Wen. It's really unfortunate that we are not able to hear Dr. Prabhash, and instead all of you have to hear to me. It will not be as exciting as Dr. Prabhash would have told you about, but I'll just summarize what this exciting paper has for us. And The review particularly goes down to look at the uniqueness, as the title suggests, of lung cancer epidemiology in Southeast Asia, since there are a lot of variations in epidemiology, genomics, also according to geography and ethnicity. And this affects the decision making for how the treatment should be optimized for the patients. And to understand these profiles, particularly with a focus on India, the authors review the data and they discuss the challenges and how to move forward. So there is a big question of in the epidemiology of lung cancer in Asia, specifically in Southeast Asia, is a proportion of patients who are never smokers, and this intrigues the population as to why what's the reason for these patients. And Dr. Prabhash and his team have delved deeply into whatever literature is available on the never smokers and of the epidemiology and the causes of cancer in these never smokers. So they have come up with a few risk factors. So adenocarcinoma is also a common histopathological subtype, and it's found in a third of patients. And there are these mutations which are noted in about 30% of patients, and some of the molecular and genetic rearrangements that are noted in patients. So these are all exciting new findings that are coming up, and they're going to answer the questions that we have been dealing with for a long time. Therapies similar to global standards, and there are new modalities, but lower resource settings like India, China, and other countries in Asia, they require a lot of political will, collaborative research, policy changes, and also advocacy at the patient level to overcome these big challenges of accessing the care that is required by the lung cancer patients. So I'll stop here, Win, and we will move on to the review from Dr. Wu, Dr. Yilong, and then probably if Dr. Prabhash is able to join us, we'll ask him to speak more.
Thank you very much, Shalini, and apologize for this technical issue. Thank you very much for jumping in a very rush situation. Now we are moving to the presentation by Dr. Wu.
Hi everyone, I'm Dr. Yilong Wu from Guangdong Lung Cancer Institute, Guangdong Province People's Hospital in China. I'm so honored and so glad to join the Lancet series webinar. Today I will present drug development and the evidence for lung cancer target therapy in Eastern Asia. This is my disclosure. So as you know, the incidence and the mortality trends for lung cancer show the significant difference among the region and the country over time, especially for the past 20 years. The lung cancer incidence and the mortality rapidly increase in the East Asia. However, some of the country or the region demonstrated the decline or the stabilization in the lung cancer incidence and the mortality, such as in the North America and the Western Europe. Maybe this related to the tobacco control. There are some difference between the East Asian and the West country in the use and the developed precision medicine and the targeted therapy in the oncology. These differences are related to the prevalence and the distribution of the certain type of cancer, the ability and accessibility of the genomic testing and the targeted drug, the regulatory and the ethical framework, and the culture and the social factor that influence the patient, the preference and the expectation. East Asian patients are known to have the higher incidence of the mutation in the EGR gene that can be targeted by drugs such as gefapixant and osimertinib. However, these drugs are often more expensive and less accessible in the East Asia than in the West country. Regularly and invasive scanner, there have been the great change in the recent 10 years in the region, especially in the China. Hi everyone, I'm Dr. Yilong Wu from Guangdong Lung Cancer Institute, Guangdong Province People's Hospital in China. I'm so honored and so grateful to join the Lancet series webinar. Today, I will present drug development and the evidence for lung cancer target therapy in Eastern Asia. This is my disclosure. So, as you know, the incidence and the mortality trends for lung cancer show the significant difference among the region and the country over time, especially for the past 20 years. The lung cancer incidence and the mortality rapidly increase in the East Asia. However, some country or the region demonstrated the decline or the stabilization in the lung cancer incidence and the mortality, such as in the North America and the Western Europe. Maybe this related to the tobacco control. There are some difference between the East Asian and the West country in the use and the developed precision medicine and the targeted therapy in the oncology. These differences are related to the prevalence and the distribution of the certain types of cancer, the ability and accessibility of the genomic testing and the targeted drug, the regulatory and the ethical framework, and the culture and the social factor that influence the patient, the preference, and the expectation. East Asian patients are known to have the higher incidence of the mutation in the EGR gene that can be targeted by drugs such as gefapixant and osimertinib. However, these drugs are often more expensive and less accessible in the East Asia than in the West country. Regularly and invasive scanner, there have been the great change in the recent 10 years in the region, especially in the China. In the China, the drug approved should evaluate the toxicity and the efficacy in the phase 2 to the phase 3 clinical trial. In recent years, China has been working on the similarly its drug approval process. It has improved the reform, the accelerated and the proper timeline. The acceptance of the global clinical trial data have been increasing, making it somewhat easy to multiple national pharmaceutical companies to conduct the global clinical trial. Based on this data, now the pricing of medicine so developed so quickly in the East Asia. I have to give the sample in the Japan. The Japan in the 2015, the cancer genomic screen project for the individual medicine in Japan. Based on this the project, 11 new drugs, 30 indicators, and 7 individual diagnoses that developed. Based on these cases, the Lung Cancer Coalition expanded the screen platform for lung cancer to East Asia in 2021. Another important platform is the Monster Screen tool. This platform, based on the multiple omic analysis, including the IA and protein expression. I think this is also very important development about the precision medicine in the Japan. And also, we are finding in the Korea, the generic landscape, the clinical use of Korea advanced the pan-cancer patient from the prospect clinical sequence, the K-master program. Based with the master K program and the precise medicine, also the debate so quickly in Korea. Interesting about another group, the APOBDC. So this is the focus on the southeast country, and then they debate the organization, and they make some the recommendation for the use of the next generation sequencer in patients for the mortality of the cancer in the Asia Pacific region. So in the precise medicine development, I think the first important about the genetic testing in the Asia. So this table show you the presentable gene the test the kit. In the beginning, the 2010, the first developed the EGR gene the test including the 21 the multiple diagnosis followings the PCR diagnosis developed in the China. And important here, based on this kit, one the clinical trial in the East Asia target the LOS1 had developed. After the trial, the finish, the LOS1 drug crizotinib had approved in the China, in the Japan, in the South Korea, and also this kit also approved by these different countries. Now there's so many the kit that had developed, including the next generation, the TKI. And also some based on this data, some the drug approved in the East Asia. So this table show you the red means the approved in the China, the blue means the approved in the Japan, the yellow approved by the Korea. So many drugs has approved based on this the precise medicine. Important very the debate about the regular authority in the Eastern Asia. So in the Asia, participation in the international control of the harmonization of the test requirement for the pharmaceutical formula use. This means the ICH. And more the whole operation and the mutual trust in the drug anticipation between the nations that regulate. And the participating information sharing in the collaboration. An important progress on drug accessibility and the reimbursement. And important, add the priority review and force track the channel. So this is some important progress in the Eastern country. So I think China, the expanded program developed so in the China is increasing the priority review, conditional approval, the usually need to oversee the drug and breakthrough the therapy. Based on this, the new law and the new regulatory, so recently, the drug approved background has a great change. I give one example. From the 2010 to the 2020, investment that the results so increase so quickly, especially from the 2015 to now, so very quickly increase the investment. And based on this data, we will find in the Chinese medicine or the chemical compound and the biological compound from the 2016 to 2019, the IND also increases so quickly in the China. Now I will introduce some of the ongoing clinical trials for the lung cancer. First, I will introduce some of the clinical trials for the resectable and the unresectable stage 3 disease. Why we are focused on this disease? Because this is the most unanswered problem in the clinical practice. So I shall give the one the clinical trial in China. This is a phase 2 the clinical trial. They are focused from the unresectable to resectable for stage 3 non-small cell cancer. 107 the patients stage 3 unresectable received the induction chemo IO the treatment. After 3 cycles, very interesting. About 25% of patients from the unresectable became the resectable. And this patient received the R0 resection and showed a very good clinical outcome. Then they only received the concurrent chemotherapy. Well, I think based on this data, we need to consider redefine the so-called unresectable stage non-small cell cancer in the future. I think this may be influence our clinical practice. Another important about the MRD guide the treatment trial in the Asian, in the global. So here also show you some of the clinical trial. I also give some example. So this is a circulation tumor DNA guide, de-expression targeted therapy for advanced non-small cell lung cancer. So when the patient received the target treatment and then the early the disease or the early progression, and then give the local treatment. After local treatment, this patient know the immediate find and then give the drug holiday. I think this is so-called de-escalation therapy. And then we are monitor with the MRD. When we are find the patient from the negative to positive, so give the patient drug retreatment. The holiday is stopped. And when it became the negative, we give the drug holiday. So very interesting. About 27% of patients, almost 2 years, they don't give any drug, but patients are still alive, very rare. About 15 to the patient, we give some drug holiday, and the median period is about 20.2 months. Totally, all the patients, the NPS 18.4 months, and the median net to the next treatment time is 29.3 months. The median drug holiday about 9.1. I think this is a very new strategy for our patient in the near future. And based on this data, the MRD became the very hot target in the clinical trial. Another is the clinical trial design, the so-called patient-centric design. So this is based on the Embry clinical trial, and then divide the patient into the different scenario. One is the follow the strict included criteria. The second extend increase criteria. If the patient know into clinical trial and then into the real world prospective observation. So this is important. It means the precisely, programmatic, and increase the modern error of the occurred clinical trial. So here also give some sample. The patient debate the 3 group finally were fine. In the more mild population, the patient the lower the efficacy than the strict including the criteria, but better than the real world clinicals. So this is a private the model for our how to evaluate one patient. So now how about the perspective? Genetic sequencing include the DNA and the methylation sequencing will be widely for studying genetic variation in the near future. The liquid biopsy for the MRD modeling is promised for clinical practice to realize the adaptive de-expression treatment and the rapid design. For particular trial, the individual with the previous unresected condition may find the need of hope through the personality and effective intervention. Cooperation effort with the accept the pace of the research around the 4 point results disparities in the disease dataset, decrease the disparity in the Asian country. Government and the regular body are likely to play an active role in developing INSO as a standard in the field. I think that in the near future, then we are discriminated the disparity and became the harmonization in the global. Thank you so much in terms of I special inspector mother special thank you for the Guangdong Lung Cancer Institute and the Guangdong the Jinan University Hematology Institute, and thank you for the authors from the Korea and from the Japan. Thank you so much for your attention. Thank you.
Thank you very much, Dr. Wu, for this amazing presentation summarizing the clinical trials conducted.
Hi, everyone. I'm Dr. Yilong Wu from...
Sorry. Thank you again, Dr. Wu, for this amazing presentation summarizing the clinical trials conducted in the Eastern Asia region. I do apologize if the presentation have been restarted. Yeah, I do apologize for this technical issue. So we can now move to the Q&A session where I will moderate this session by asking questions to our panelists. I will kick off this session with Dr. De Guzman. From your presentation, we have learned how air pollution and extreme weather events can impact lung cancer and undermine patients' care in the region, in the entire region. So my first question is, considering the large economic, cultural, and resource diversity across countries in the region, what should we do to reduce the gaps and prevent the continuing rise of lung cancer cases and deaths? Over to you, Rosa.
Okay, thank you. Yes, that's correct that Asia is a diverse region. What the impact of climate change do not know boundaries in terms of countries and areas and communities. So as healthcare professionals, we can help in reducing the gaps and reducing the incidence of lung cancer by participating on different fronts, different levels. But what is important is as individuals, whether you're an academician, you're a clinician, a researcher, or scientist, is to be aware of what are the real impacts and threat of climate change. We see and hear it in the news almost on a daily basis. We read it on papers, but we are all busy individuals, busy professionals. So we have to learn more, educate ourselves, and educate our patients as well that the impacts are there, not only in terms of air pollution, the increasing exposure to environmental air pollutants, but also the impacts that it may have on their access to care, access to treatments from screening, diagnosis, and treatments. So first and foremost, I think it's more of to be more engaged on what's happening.
Yeah, thank you very much, Rosa, for your answer. And my second question is, in the series, we have published an inspiring story of lung cancer survivor, Adelina. Can you tell us more about people living with lung cancer and how climate change can impact their lives?
Yes. Adelina is an elderly patient diagnosed with lung adenocarcinoma and with EGFR mutation positive disease, and had dramatic improvement, symptom improvement with oral TKI. But most of the patients, they may be very much engaged in their treatments, in their follow-ups, and following also what their doctors and oncologists advise them to do. But most of them are not aware that in addition to complying with their required treatments, it's important to be in a healthy, clean environment. That's what the experience, what we saw with Adelina, that a healthy environment, clean air helped her in her recovery. So it's important for us, of course, drug development, clinical research are important to advance treatments and diagnostic strategies, especially in this era of precision medicine. But we have to be aware that with these drug developments and all the advancements in treatment, not only for lung cancer, but in cancer in general, we have to promote and protect the well-being of our patients by providing them good environmental advice, and of course, if possible, and with opportunity and with an appropriate network to promote healthy air, because it's not wise to advise patients to be compliant with their treatments, schedules, and medicines if they are continuing breathing unhealthy air.
Thank you very much, Shalini. Yeah, I was very, very inspired about Adelina's stories. I think was quite very emotional reading about these correspondence, these patient profiles. So I would encourage you, if you have time, to just go and read this wonderful story about Adelina. Let's move to Dr. Wu. For Dr. Wu, this is a question for Dr. Wu. Could you please talk about the challenge of targeted therapies approval in Asian countries? Why it takes longer time for the approval? What is the gap? What effort we can do to address the gaps? Over to you, Dr. Wu.
Yeah, thank you. So I think this is a very good question because the East Asia or the whole Asia, the regulatory authority is very different from the West country, especially very different from the FDA in the US. So we and also in the China, including the South Korea or the Japanese or the Japan, we have the so different from the regular authority. In general, we are needed from the early stage, pre the clinical, and then the phase 1 to phase 3, the clinical trial, and then the regularity to find the rational or the medical need, and then the approve. And before, I think that very important, the most innovation drug developed in the West country or in the Europe, and they are enrolling the Asia country. So in the early, the later stage, and in this situation, in general, we need the added some the so-called bridge clinical trial, and then the authority could approve this drug. So I think this is a gap that make our the proof that the long time behind the FDA or the Europe, the Europe. So now I think since the 2020, just behind the COVID-19, and now the situation of the regular authority in the Japan, Korea, and China has greatly changed. Now, just I in my slide, my talk, we have so many channels to rapidly approve the drug. So this is why we have the harmonization with the West country of the US. Another point is so now there's so many clinical trials in the early stage involving the East Asian country. such as now, so many phase 1 clinical trial, the China and the Korea and Japan also joined this drug development. So this is also one we overcome the gap, the very important step. Finally, in the Japan and the Korea, in the China, we have so many innovation drugs and also developed so quickly. We are also involving in the Western country and the Europe. So I think this more and more the factor that make our rapidly approve our drug between the West and the East country. Thank you.
Thank you very much, Dr. Wu. I'll move to Dr. Liu now. The question is, along with the rapid advances in precision oncology, what should we consider when designing clinical trial for personalized medicine? You mentioned patient-centric clinical trial could be a promising approach, but are there any limitations for this kind of trial?
Oh, yes. Thank you for this question. I think firstly, I want to say that for the personalized clinical trial for the precision medicine, when we're designing the clinical trial, I think the first point is really important is for the biomarker selection. We need to do a great job to identify and to validation the selected biomarker in the, for example, for the lung cancer patients. So they just need a great job to do with the preclinical and clinical data. The retrospective clinical data in these populations with this retrospective study design is really important that we could provide the evidence for the registered clinical trial. Secondly, I think the molecular profiling is really important for the personalized medicine for the clinical trial. We need to know what happened before the targets and the agents. So the baseline and when the disease progression, the tumor tissue or the blood sample is with the sequencing testing result is really important that we need to know what happened for the patients who is who have better response, who have poor response. So maybe we could conclude that additional biomarker is also very good, and we could know what mechanism resistance in this population. The second question is for the patient-centric clinical trial. In last year, we published phase 2 patient-centric clinical trial. This is for the patients with HER2 mutation, a rare genetic variation in lung cancer. So firstly, we need to know what is patient-centric clinical trial. So this clinical trial is to prioritize the patient's outcome in all stages in a clinical trial. That means in the study design, in enrollment, the data completion and outcome reports that the patients, we need to know what patients need, and they could participate in the stages of clinical trials. So in the paper that we published on Nature Medicine, we test agents for the patients with HER2 mutation in a broader population. We excluded, we tested this population in a broader population where some patients not fulfilled the clinical trial, they also come into this clinical trial. So I think the limitation for this kind of patient-centric clinical trial have 3 points of limitation. Firstly, for the ethics committee, they have to take high risk to test the agents in a poor basic condition populations. Secondly, for the patients, they have to bear the high risk of drug toxicity because of his poor basic conditions. But I think the big limitation is for the teamwork. So additional resource and additional engagement in the teamwork, we need to know. For example, we need to monitoring the efficacy and toxicity of this drug in this kind of broader population. And additionally, we need a large sample size in this kind of population. So, and the outcome is not unsure. We don't know if it could bring a decreased outcome and increased toxicity in this population. So, all the team and the physician and the patients have to bear high risk in this patient-centric clinical trial. But this is what we need to know. What if the drugs still work in this kind of broader population, in this real world?
Thank you very much, Dr. Liu. Thank you, everyone, for running through all these questions. I would like to go through the Q&A session, the Q&A chat, because we have a few questions from our audience. So I'll read a few questions, and then it would be nice to have some thoughts from all the three speakers. So the first question, I think is a very good question, is from Manish Kumar Mandal about social stigma. So social stigma is the main cause of hiding chronic fatal disease like cancer in countries like Nepal, India. So can we convince people to become the part of the research related to cancer in our region? It is difficult to ask for data for this research. So I will first ask this question to Rosal, and if you have some thoughts about that, about social stigma and how we convince people to just join trials or get treatments in Asia. So over to you, Rosal.
Yeah, thank you, Vin, for the question. Yes, that's true. Social cultural barriers are still a reality for most countries in Asia. We have to understand that people, individuals, and patients may have different beliefs, religious beliefs, different practices, different cultures, different norms. So we have to understand where the stigma is coming from. I think society plays an important role. Professionals, cancer professionals, doctors, even if we want to educate patients on early cancer screening, detection, or even advising patients to go on for treatment, there may always be that resistance or reluctance because of various factors. It could be economic issues, it could be lack of support from all the other stakeholders. So we have to find out what's the main or the root cause of that stigma. So very important is the role of socio-cultural aspects in that concern, in that issue.
Thank you, Rosal. So I would like to pass to Dr. Wu. Can you give us some thoughts about how stigma can impact and how we can convince people to just join the trials in this case or treatments? Yeah, over to you, Dr. Wu.
Yeah, so I think the treatment in the Asia, I think we need to depend on the area. So one is we need more the cooperation in the clinical trial, and also we need more the cooperation with the innovation drug or the innovation strategy called developed for the patient. So I think the most important, why I need to think the regularly the environment, we need promote the country to cooperation with another country, especially in the Asia. We need the cooperation with all the Asian countries all together, and then make the treatment guideline and so on. And based on this cooperation, we could make the better than before, and then better the best care for our patient. Thank you.
Thank you, Dr. Wu. And Dr. Liu, what do you think about the social stigma issue related with lung cancer treatments in Asia?
I think, as Professor Wu said, the collaboration in different countries, so especially for the politics in different countries, it is very important because it involves that the data sharing, if it could increase the time for the drugs into the before the approval to the market for it will be more good for the patients, accessible to the different agents, especially for the patients with rare genetic variations. Yes, this is my point.
Thank you very much, Dr. Liu. There are a few questions related to climate change and cancer. So I'm going to read these questions for Roselle. There is a question from Meng Li. The first question, yeah, climate change and air pollution are closely related but different issues. Would you please comment on the possible impact of their interaction on lung cancer burden? Over to you, Rosal.
Yeah. So, yeah, that's correct that climate change and air pollution are entirely different, and they're separate drivers in terms of lung cancer incidence. But in an aspect that they're different, there are also several elements that they are interconnected. As what I have presented, the accumulation of greenhouse gases that traps the heat from escaping the earth and to escape to the space is being trapped by the accumulation of carbon dioxide, methane, and nitrous oxide. And so these greenhouse gases, when they accumulate, they play an important role because these are also brought by the fossil fuel emission that comes from transportation, from industrial power plants. So in short, climate change is being driven by human activities that have accumulated for several decades, several years. So the unhealthy air that accumulates in the atmosphere, knowing that this air pollution contains carcinogens, including PM2.5, particulate matter 2.5, which is a known carcinogen, is increasing the risk of cancer. There are studies, growing studies, that there are that air pollution is also linked to development of breast cancer and other cancers. So it's closely interrelated. This may be different change in air pollution there, but they are interconnected by various factors and elements. So we have to understand there's a close interconnection, close intersection between climate change and lung cancer, not only in the risk, the impact on care, the impact on cancer outcomes, but also the way patients will be able to access important healthcare services.
Thank you very much, Rosa. There is a very interesting question from Ejref Selik. Sorry for my pronounce. This question, I guess, could be a very good question for Dr. Pramash, but unfortunately today is, yes, a lot. I mean, we had many issues to have him online. I want just to say that the question is there any association between bacterial lung cancer? Dr. Pravash wrote the review focused on lung cancer. And if you go through the review, you can also have some information of the interaction between tuberculosis and lung cancer. So if you want to learn a bit more, you can just read the review. And also, if you want more question, you can straight email Dr. Pravash. He will be very happy to answer this question. So unfortunately, we don't have much time left, and we need to close the Q&A session. So as we come to the end of today's webinar on the rise tide, trends and challenge of lung cancer in Asia, we hope you find the information shared today both informative and inspiring. Addressing lung cancer is a significant challenge, even more in low and middle income countries. But with continued research, education, and collaboration, we can make meaningful progress in prevention, early detection, and treatments. On behalf of eClinicalMedicine, the Lancet Regional Health Southeast Asia, and the Lancet Regional Health Western Pacific, I'd like to extend a big thank you to our speakers, all the authors and co-authors for the articles, our marketing and communications team for organizing the webinar and the hub, all the editors who contribute to the series, our production team, and to all of you for joining us today. Your participation and engagement make these events valuable and enjoyable. We hope you find today's webinar useful and that you will be able to apply what we have learned. Have a wonderful rest of the day, and we look forward to see you at our future events. Again, thank you everyone, and ciao.